Most people believe that if a surgeon recommends an operation, it must be the right choice. The doctor knows best. The hospital has the equipment. The consent form is waiting. Just sign here. I believed that once too, until I started paying attention. Paying attention to the patients who walked in for a straightforward procedure and walked out as different people. Not healed, different. A woman who arrived with a stiff hip and left with a mind that never fully returned to her. A man who beat the cancer on the scan, but lost the last good year of his life to the operation that removed it. Here is the truth nobody says out loud. The older your body is, the harder it has to fight simply to survive the surgery itself. Not the illness, the surgery. My name is Dr. William Lee, and today I am going to walk you through 5 surgeries that carry serious hidden risks for anyone over 60. Before we begin, one quick thing, because it shapes everything that comes after. If you are over 60, or you can feel 60 approaching, and what you truly want is to live longer, stronger, and healthier, with the independence to make your own choices for years to come, then give me 10 seconds. I took everything I tell my own patients and put it into one simple plan. It has already helped thousands of people live their best life after 60. The link is right there on your screen. You do not need to write anything down. Just take a look once we are finished here. And if today's video helps you, do me one small favor. Subscribe, give it a like, and leave a comment. It helps me put this in front of more people who need to hear it. All right, let me ask you something. If you take a brand new car and a car with 200,000 miles on it, and you run them both through the same punishing stress test, do you expect the same outcome? Of course not. And yet, for decades, medicine treated a 70-year-old body the same way it treated a 40-year-old one. Same protocols, same recovery expectations, same timelines. That is beginning to change, but not nearly fast enough. Here is what happens inside an older body when it goes under general anesthesia. The heart has to labor harder. The lungs take longer to clear the drug. The kidneys slow down as they process the medications. And the brain, this is the one that catches people off guard. The brain becomes temporarily disoriented in ways that can last weeks, sometimes months. Doctors have a name for it: post-operative cognitive dysfunction. And in patients over 70, it happens far more often than anyone likes to admit. Now, I want to be crystal clear about something. Age by itself is not a reason to avoid surgery. I have operated on 80-year-olds who recovered faster than some 50-year-olds. Age is only a number, but frailty is not. Frailty is a genuine medical term. It means the body's reserve, its ability to bounce back, has fallen below a critical threshold. Roughly 40% of people over 75 show signs of frailty. That number climbs towards 60% past the age of 85. So here is the real question. It is not whether someone can survive the operation. It is whether they can survive the recovery. Those are two very different things. And that difference is about to matter enormously. Surgery number 1. Open heart surgery in frail patients. Coronary artery bypass grafting, CABG as we call it, is one of the most common major operations performed on older adults. The concept is simple. Your arteries are blocked, we reroute the blood around the blockage, and for the right patient, it works beautifully. But here is what the brochure never shows you. Open heart surgery requires stopping your heart completely. We place you on a bypass machine, a device that does the work of your heart and lungs while we operate. For a 60-year-old in decent shape, that is manageable. For a 78-year-old with kidney disease, mild diabetes, and early cognitive decline, that machine is a full-scale assault on every organ at the same moment. Studies show that in frail elderly patients, open heart surgery carries a 30 to 40% risk of major complications: stroke, kidney failure, prolonged confusion, extended time on a ventilator. And here is the figure that stops people cold. Up to 15% of high-risk elderly patients do not survive the first 30 days after this operation. So what is the alternative? In many cases today, there is one. It is called TAVR, transcatheter aortic valve implantation, a catheter-based procedure that never requires stopping the heart or opening the chest. Less dramatic than surgery, but far kinder to a body that needs kindness, not a battle. Does this mean you should refuse heart surgery? Absolutely not. It means you should ask your surgeon a single question. Am I a candidate for a less invasive approach? That one question could change everything. Surgery number 2, aggressive spinal surgery. Back pain in your 60s and 70s is almost universal. I do not know a single patient over 70 who has not at some point mentioned their back. And the solution offered more and more often is spinal surgery. Fusions, multi-level decompressions, hardware bolted up and down the spine. Now, I need you to hear this clearly. Some spinal surgeries are absolutely necessary, no argument. A spinal cord being actively crushed, causing loss of bladder control, or the beginning of paralysis, needs surgery immediately. But elective spinal fusion for chronic back pain in an elderly patient, the evidence there is genuinely troubling. A major study published in the journal Spine found that in patients over 65, complex spinal fusion carried a complication rate exceeding 40%. 40%. And these were not minor complications. Blood clots, infections, hardware failure, and something called adjacent segment disease, where the vertebrae above and below the fused section begin to break down because the mechanics of the entire spine have been permanently altered. The hardware locks one section rigid, and the rest of the spine pays the price. And here is what frustrates me most: the pain relief itself. Studies show that for many elderly patients with degenerative spine disease, aggressive surgery provides no better long-term pain relief than physical therapy and targeted injections. No better, but with dramatically higher risk. I had a colleague, a gifted spine surgeon, who once told me, "Sometimes the best operation is the one you choose not to do." I think about that sentence often. Have you ever been told surgery was your only option for back pain? Write it in the comments. I genuinely want to know how many of you have heard those exact words. Surgery number 3, major cancer resections. This one is the hardest to talk about because the moment someone hears the word cancer, the instinct is immediate and overwhelming. Cut it out, remove it, get rid of it now. And I understand that completely. I would feel exactly the same. But here is what 2 decades in medicine has taught me. The goal of treatment is not simply to remove the tumor. The goal is to give the patient more good years of life. And sometimes, not always, but sometimes, major surgery in a frail elderly patient does the opposite of that. Let me give you a real example. Pancreatic cancer surgery, the Whipple procedure, is one of the most complex operations in all of medicine. We remove the head of the pancreas, part of the small intestine, the gallbladder, part of the bile duct. The operation itself runs 6 to 10 hours. In younger, healthy patients, it can be life-saving. In an 80-year-old with heart disease and reduced kidney function, the surgery may technically succeed. The tumor is gone, and the patient still passes away within weeks, not from the cancer, but from the operation. This is called futile surgery, and it happens far more often than anyone wants to acknowledge. A landmark study from the American College of Surgeons found that nearly 1 in 5 elderly cancer patients who underwent resection experienced what we call failure to rescue, meaning a complication arose that the weakened body simply could not survive. So what is the conversation worth having? Ask your oncologist this, and ask it plainly. If we do not operate, what do watchful waiting, radiation, or targeted therapy look like for someone my age and my health? That question opens a door many patients never even knew was there. And sometimes, what waits behind that door is genuinely the better path. Surgery number 4, elective joint replacement in severely ill patients. Hip and knee replacements are among the most successful operations ever developed. I say that without hesitation. For the right patient, a new hip transforms quality of life. People go from barely shuffling across a room to chasing their grandchildren. It is remarkable. But here is where it grows complicated for older adults. The word elective means the surgery is planned, not an emergency. You have time to think, time to prepare, and crucially, time to ask whether this is the right moment for your specific body. Because here is what the statistics reveal. In patients over 75 with 3 or more serious conditions, heart disease, diabetes, chronic kidney disease, obesity, elective joint replacement carries a significantly elevated risk of complications around the time of surgery. Blood clots are the biggest danger. Deep vein thrombosis, clots forming in the legs, can travel to the lungs and become life-threatening. In elderly patients with reduced circulation, that risk is substantially higher. Add pneumonia from lying still too long. Add hospital-acquired infections, and the picture becomes far more complex. I want to be precise, because I do not want to frighten anyone away from an operation that could genuinely help them. The question is not, should I ever have a joint replacement? The question is my body in the best possible condition right now? Optimizing blood pressure, blood sugar, weight, and cardiovascular fitness before elective surgery can lower complication rates dramatically. Some hospitals now require a formal prehabilitation program before they will even schedule these operations for high-risk elderly patients, and that is exactly the right approach. Has your doctor ever mentioned prehabilitation to you before a planned surgery? Most people have never even heard the word, and they absolutely should have. Surgery number 5, emergency abdominal surgery. Now I need to pause here because this one is different from the rest. You do not choose emergency surgery, it chooses you. A perforated bowel, a ruptured appendix, sudden internal bleeding, these situations do not wait for a calm conversation in an office. But here is why it belongs on this list. Understanding the risks in advance, before the emergency ever arrives, changes how families make decisions in those terrifying moments. Emergency abdominal surgery in patients over 75 carries some of the highest mortality rates in all of surgery. We are talking 30 to 50% in the most severe cases. Not because the surgeons are unskilled, but because an elderly body under sudden trauma is fighting on too many fronts at once. The liver, the kidneys, the heart, the lungs, all hit at the same instant. And the inflammatory response that a younger body would settle within days can spiral in an older body into something called systemic inflammatory response syndrome. When organs begin shutting down one after another, it is exactly as serious as it sounds. So what can you actually do with this knowledge? 2 things. First, do not ignore abdominal symptoms. Persistent pain, bloating, changes in bowel habits in someone over 60 deserve prompt attention. Catching a problem early means treating it before it ever becomes an emergency. That single habit can change everything. Second, have the conversation with your family now, not in a hospital corridor at midnight, now. What are your wishes if emergency surgery becomes the only option? What quality of life matters to you? These conversations are not morbid. They are one of the most loving gifts you can give the people who will one day be standing in that corridor. All right, we have covered 5 surgeries. Now let us talk about what you actually do with this knowledge, because information without action is just anxiety, and anxiety is the last thing I want for you. Before any major surgery, planned or recommended, there are 4 questions every patient over 60 should ask. Write them down. Question 1. What happens if I do not have this surgery? A good surgeon will answer honestly. If the answer is that nothing urgent changes in the next 6 to 12 months, then you have time. Time to think, time to get a second opinion, time to strengthen your body. Question 2. Is there a less invasive alternative? Medicine has transformed in the last 15 years. Robotic surgery, endoscopic procedures, catheter-based interventions. Options that did not exist a decade ago are now available in most major hospitals. Question 3. What does recovery realistically look like for someone my age and my health profile? Not the average patient, you. Your heart, your kidneys, your medications, your living situation. The answer should be specific, not generic. And question 4, the one almost nobody asks. What is your personal complication rate for this procedure in patients over 70? Surgeons track this. They know their numbers. A confident, honest surgeon will tell you. If the question makes them uncomfortable, that discomfort is itself information worth having. Now I want to give you something most patients are never told, because it can shift your odds more than almost anything that happens in the operating room itself. If you decide a surgery is right for you, what you do in the 2 to 4 weeks before you walk through those doors matters enormously. Surgeons spend years mastering the procedure. Almost nobody spends 2 weeks preparing the body that has to survive it. Let us fix that. The first piece is prehabilitation. It is training for an event because that is precisely what surgery is. Your body is about to run a marathon while you sleep. So in the weeks before, you build reserve. You eat more protein because protein is what your body rebuilds tissue with, and most people over 60 quietly undereat it. You walk every single day, even just around the block, because the stronger your legs and lungs are going in, the sooner you are up and moving after. And getting up and moving is what prevents the blood clots and the pneumonia I described. And if you smoke, even stopping 2 weeks before surgery measurably lowers your risk of wound and lung complications. 2 weeks, that is all. I have watched prehabilitation turn a high-risk patient into a routine one, and it costs nothing but effort. The second piece is the conversation almost nobody has, the one with your anesthesiologist. Remember the brain fog I mentioned? Post-operative cognitive dysfunction? There are real, practical things that lower the odds of it. Ask for a preoperative anesthesia consultation. Bring a complete list of every medication and every supplement you take, and I mean every one. The fish oil, the herbal sleep aid, all of it. Because some of them interact with anesthesia in ways that surprise people. Ask whether a regional or spinal anesthetic, where they numb only the area instead of putting your entire brain under, is an option for your procedure. For many hip and knee operations it is, and it is often gentler on an older brain. And here is a small thing that sounds almost too simple to matter. If you wear hearing aids or glasses, ask to keep them with you right up until the moment you go under, and back on the moment you wake. Patients who can see and hear when they wake up get confused far less often. The research on hospital delirium is clear on this, and it costs nothing. The third piece is the part everyone forgets until they are living it. The recovery setup at home. Arrange your help before the surgery, not after. Who is driving you? Who is staying with you the first few nights? Where is the bed? Because the fewer stairs you climb in the first week, the better. Clear the rugs and the cords you could trip over. Fill the prescriptions ahead of time so you are not sending an exhausted family member out to a pharmacy at 9 at night. The first 72 hours after you get home set the tone for the entire recovery. A body that is not fighting a fall or a missed dose heals faster. Watch for the warning signs in those first days too. Sudden confusion, a fever, a calf that is swollen, hot, or painful. Any of those you call, you do not wait. And the fourth piece, please, get the second opinion. I know it feels awkward. People worry they will offend the surgeon. Let me put that worry to rest right now. A good surgeon expects it. A good surgeon welcomes it, because they would want one for their own mother. Bring your scans and your records so the second doctor is looking at the same picture. And if two qualified surgeons studying the same body and the same images land on two different recommendations, that is not a problem. That is information. That is exactly the kind of thing you deserve to know before anyone picks up a scalpel. None of this is about fear. It is about walking in prepared instead of merely hopeful. The patient who arrives strong, informed, and organized is a fundamentally different surgical risk than the one who arrives frightened and unprepared, even when the operation is identical. You have far more control over which of those two people you are than anyone has ever told you. There is one more thing I have to give you, and it may be the most useful of all, because it is about reading the recommendation itself. Over the years, I have learned that the way a surgery is presented tells you almost as much as the surgery does. So here are the warning signs. When you hear them, you slow down. The first red flag is speed. You are being rushed. We need to get you on the schedule right away. Now, if you are bleeding internally, yes, fast is exactly right. But for a planned elective operation, real urgency is rare, and a true professional knows that. If a knee that has hurt for 10 years suddenly must be replaced this month, ask why this month. The pressure to decide quickly is almost never about your body. It is about a calendar. The second red flag is a single path. You leave with exactly one option, surgery, and no mention of anything else. Remember, by the time you are 70, there is almost always more than one road. Medication, physical therapy, injections, watchful waiting, a less invasive version of the same procedure. If none of those even came up, it is not because they do not exist. It is because nobody put them on the table. The third red flag, the one people miss entirely, is that the do nothing for now option is never discussed. Watching carefully and treating conservatively is a legitimate medical choice, and for many conditions in older adults, it is the right one. If your surgeon cannot or will not tell you what happens if you simply wait and monitor, you do not yet have enough information to consent to anything. The fourth red flag is how your questions land. You ask something hard. What is your complication rate? What are my alternatives? And instead of an answer, you get a brush off. A good surgeon does not get defensive when you ask the very questions they would ask for their own family. If the questions make the room tense, pay attention to that tension. It is telling you something. And the fifth red flag is a recovery that gets glossed over. Oh, you will be back on your feet in no time. That is not a recovery plan. That is a sales line. The honest version sounds different. Here is week 1. Here is when you will need help at home. Here is the part that is genuinely hard. Specificity is a sign of respect. Cheerful vagueness is a sign that someone is managing your feelings instead of informing your decision. Now, I want to say this carefully because it matters. None of this means your surgeon is a bad person. The overwhelming majority went into medicine to help, and they work brutally hard. But you have to understand the system they operate inside. It is built around doing procedures. It rewards doing procedures, and it runs on 12-minute appointments where there is no time to walk through 5 alternatives. So the bias toward action is rarely personal. It is structural. And the one thing that reliably cuts through a structural bias is an informed patient sitting across the desk asking the questions out loud. So what does good actually look like? A good surgical conversation slows down. The surgeon draws the problem out for you, sometimes literally on paper. They name the risks before you have to ask. They tell you unprompted what the alternatives are and what happens if you wait. And the very best of them will say the words you are hoping to hear. If you want a second opinion, I think that is a good idea, and here is who I would send my own mother to. When you hear that, you have found someone to trust. Hold on to them. And one more small thing that does more good than almost anything else on this list. Never go to a major surgical consultation alone. Bring someone with you. In 15 years of practice, I have watched it happen again and again. The moment a patient hears a frightening word, cancer, surgery, blockage, a fog descends, and from that second on, they barely hear another word. Afterward, in the car, they cannot recall half of what was said. It has nothing to do with intelligence. It is simply what fear does to the human brain. So bring a second set of ears, someone calm who is not the one receiving the news. Have them take notes, or with permission, record the conversation so you can replay it at home. And tell them beforehand the questions you want asked, so that if the fog comes down for you, they can ask on your behalf. I want to leave you with something hopeful, because this is not a video about fear. It is about options, and those options have never been more powerful. Minimally invasive surgery has transformed what is possible for elderly patients. Laparoscopic procedures, small incisions, camera-guided, dramatically shorten recovery. Robotic-assisted surgery allows a precision human hands alone cannot achieve. And catheter-based cardiac interventions have opened doors for patients who never could have survived traditional surgery. Beyond surgery itself, optimized medical management is genuinely powerful. The right medications, supervised physical therapy, targeted injections, and nutritional support can manage many conditions that once seemed to demand a knife. The body wants to heal. Sometimes our job is simply to get out of its way. Let me tell you about a patient. I will call him Gerald, 71, a retired engineer, sharp as a tack. He came to me after 3 separate surgeons recommended open heart surgery for a blocked artery. 3 surgeons, 1 answer. Gerald was not afraid of surgery. He was afraid of losing himself. He had watched his wife come out of a major operation 2 years earlier, confused, exhausted, and never quite the same. He told me, Dr. William Lee, she went in as my wife and came out as someone I had to take care of. That sentence has stayed with me. When I reviewed Gerald's full profile, his kidney function, his frailty score, his cognitive baseline, I sat with him for 40 minutes, not 15, and I told him the truth. Surgery was an option, but so was an aggressive medication protocol combined with cardiac rehabilitation, and for his specific profile, the 5-year outcomes were comparable. He chose the non-surgical path. That was 4 years ago. Last month he sent me a photograph, standing at the top of a hiking trail in Colorado with his 2 granddaughters, both taller than him now, grinning like he won the lottery. Here is the single most important thing I will say today. A surgical recommendation is not a verdict. It is the beginning of a conversation. You are not a passive recipient of medical decisions. You are an active participant in your own care. The surgeon holds the scalpel, but you hold the choice. And that choice, made with full information and clear eyes, is the most powerful tool in all of medicine, more powerful than any operation I have ever performed. Let us bring it together. 5 surgeries with serious hidden risks after 60. Open heart surgery in frail patients, where less invasive alternatives now exist. Aggressive spinal fusion, where the evidence for pain relief is weaker than most are told. Major cancer resections, where the goal must always be more good years of life. Elective joint replacement in severely ill patients, where timing and preparation matter as much as the surgery. And emergency abdominal surgery, where the best protection is catching problems early and speaking honestly with your family. None of this means avoid all surgery. Surgery saves lives every single day. I have seen it, I have been part of it, I am proud of it. The message is simply this: be an informed patient, ask the hard questions, request the alternatives, get a second opinion, and if necessary, a third. Your age is not a weakness. What question would you most want to ask your surgeon before a major operation? Tell me in the comments. And if this helped you or someone you love think more clearly, share it. That one share might be the most important thing you do today. Take care of yourselves, stay curious, keep advocating for your own health. You deserve a surgeon who explains everything and a team that treats you as a partner. And one last thing, everything I have shared is general medical information drawn from published research and clinical experience. Every person's situation is unique. Before making any decision about surgery or treatment, have a full, honest, unhurried conversation with your own doctor. They know your history, they know your body, and that conversation is exactly where good medicine truly begins, always.